You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to Season 3 of the Medscape Type 2 Diabetes podcast series. Today we'll be discussing chronic kidney disease in patients with type 2 diabetes, SGLT2 inhibitors versus GLP-1 receptor agonists. How and when do we choose which agent? First, let me introduce my guest, Dr. Liana Billings. Dr. Billings is the Vice Chair of Research in the Department of Medicine, Endeavor Health in the North Shore Hospitals. She is the Director of Clinical and Genetics Research in Diabetes and Cardiometabolic Disease and of Personalized Medicine in the Diabetes Consultation Clinic. She is also a Clinical Associate Professor of Medicine at the University of Chicago Pritzker School of Medicine. Dr. Billings, welcome to Medscape in Discussion Type 2 Diabetes podcast.
Thank you for having me.
It has been such an exciting time to be involved in the treatment and research for management of patients with type 2 diabetes in general. And over the past decade, as you well know, there have been countless studies that have fundamentally changed how we practice in diabetes. I know you've been involved in a lot of the studies, and I am looking forward to learning how to apply some of that information into clinical practice. So our topic today is the management of CKD and type 2 diabetes, specifically how to use the newest guidelines to determine appropriate anti-hyperglycemic therapies. So getting started, Dr. Billings, would you please provide an overview of the magnitude of the problem of CKD and type 2 diabetes?
Yes, happy to. Unfortunately, CKD and type 2 diabetes is highly prevalent. So about 20 to 40% of people with diabetes have chronic kidney disease or CKD. CKD can progress to end-stage renal disease and then the need for renal replacement therapy like hemodialysis. The CDC reports that prevalence of CKD is increasing, and this could be increasing because perhaps it's an increased incidence of diabetes. We are recognizing CKD more often, and people are living with type 2 diabetes longer.
Well, just to make sure we're all on the same page, can you provide a definition of CKD and type 2 diabetes?
CKD and type 2 diabetes refers to the gradual loss of kidney function due to the result of prolonged high blood glucose levels. We refer to CKD that is caused by diabetes as diabetic nephropathy. And we determine whether someone has CKD in diabetes by measuring their creatinine or cystatin C to calculate the estimated glomerular filtration rate or eGFR. And we also measure urinary albumin to creatinine ratio, or also the acronym for that is UACR. A normal eGFR is over 90 and a normal UACR is less than 30 milligrams per gram. The eGFR we usually use to calculate using the CKD epi equation, which is very easy to find online. And also sometimes it's automatically calculated in the electronic medical record. And then once we have the eGFR, we can better define the stage of kidney disease that the person has, and that's stages 1 through 5.
I think it's also important to point out that someone could have a normal eGFR and still have diabetic kidney disease if they have abnormal levels of urinary albumin. And I think that's an important measure and consideration when we're defining our patient's CKD status.
And that brings up a really good point, is that we need to assess CKD not only by measuring creatinine or cystatin C in a blood sample, but also doing the UACR, or the urinary albumin to creatinine ratio. And we're very good at capturing eGFR through testing. Usually it's estimated that we capture that 80 to 90% of the time in people with type 2 diabetes, but we're falling short on capturing UACR in people with type 2 diabetes. It's estimated that perhaps we're only capturing it about 40 to 60% of the time. So to your point, in fact, we may miss people who actually have a normal kidney filtration, but actually have albuminuria that is an early sign of diabetic-related kidney disease.
That brings up a good point. Our health system has been using UACR testing as one of the quality metrics to help, and we get paid a little more for our quality metrics. So it's really helped to have people tune into doing that. But it's my understanding, and I'd be interested in your input, that even though we have all this information in the chart, that to actually have the diagnosis placed into the problem list so that it receives attention is woefully less than even that 40 to 60%.
I agree with you. We've seen that as well, that people are not capturing the actual diagnosis of either diabetic nephropathy or the CKD stage in the chart. And we also, at our organization, also look at UACR, and it's a quality metric as well, that we actually have been improving upon since using some interventions and trying to capture that so that our clinicians understand the importance of capturing that information and our patients are aware of the prevalence of CKD and type 2 diabetes.
We're going to be speaking a lot about the medications in a bit, but I just want to highlight the fact that, a person with a normal eGFR and a urinary albumin of 50 would still qualify for consideration for use of these disease-modifying agents, so to speak, in their treatment of type 2 diabetes.
What you said is exactly true. If they have a normal eGFR and elevated UACR, they would qualify for these disease-modifying therapies to prevent the progression of kidney disease.
Well, that leads to the next question, and that is, what are all the ways that we can prevent the progression of CKD and type 2 diabetes? There are multiple considerations that we should be presenting to our patients. Could you please review those?
Yes, I'd be happy to. Fortunately, we have lots of ways that we can prevent chronic kidney disease and type 2 diabetes or prevent the progression of already established CKD and type 2 diabetes. So we focus very much so on blood glucose control. We know far and away that high blood sugars can increase the risk of chronic kidney disease and increase the risk of progression of chronic kidney disease. We also know that controlling cholesterol, blood pressure, maintaining a healthy lifestyle and diet and weight, and avoiding nephrotoxic agents like NSAIDs can also reduce your risk of getting CKD or progressing CKD. Additionally, for people who are known to have CKD, like the person you mentioned who'd had an elevated UACR but normal GFR, studies have shown that renin-angiotensin system inhibitors or RAS inhibitors, such as ACE inhibitors or ARBs, sodium glucose transport 2 inhibitors or SGLT2 inhibitors, and non-steroidal mineralocorticoid receptor antagonists or non-steroidal MRAs like finerenone reduce the risk of progression to kidney disease. And additionally, most recently, we've had a trial, the FLOW trial, showing the benefit of semaglutide, a GLP-1 receptor agonist, in reducing the risk of progression to kidney disease.
So it'd be interesting to start with the SGLT2 inhibitors and just provide a synopsis of the impact that addition of SGLT2 inhibitors on top of ACE and ARBs and what they show in patients with type 2 diabetes and CKD.
So I think the best way to describe the impact of SGLT2 inhibitors is to walk through 3 key trials that were examining SGLT2 inhibitors in CKD and type 2 diabetes. And those trials were the CREDENCE trial with canagliflozin 100 milligrams, and that was published in 2019. The DAPA-CKD trial with dapagliflozin 10 milligrams in 2020, and the EMPA-KIDNEY trial with empagliflozin 10 milligrams in 2023. Just to take note that DAPA-CKD and EMPA-KIDNEY trials also included people without diabetes in addition to people with diabetes. And additionally, each trial had slightly different inclusion criteria based on the eGFR level and the degree of albuminuria. And the trials ranged from 2 to 2.5 years. All 3 of the trials showed that their respective SGLT2 inhibitor versus placebo showed a 30 to 40% risk reduction of progression of kidney disease and risk of kidney failure. So quite incredible results, 30 to 40% reduction, almost half. And it is notable that all trials also showed a decreased risk of cardiovascular events with SGLT2 inhibitor therapy.
As you indicated, the FLOW trial was recently published showing an impact of semaglutide on kidney outcomes. Could you please give us a synopsis of the results of that study?
So as a result of these trials, all these agents have now the FDA indication for treatment of diabetic kidney disease in people who have persistent albuminuria over 200 to 300 receiving optimal ACE or ARB treatment. Canagliflozin is approved in diabetes, and empagliflozin and dapagliflozin are approved with or without diabetes. Just want to make a clinical comment to what you said earlier. Experts in the field will also use these agents for people who have lower levels of albuminuria, not just the 200 to 300 mark, but that is what was part of the inclusion criteria in those trials.
Just to add, all of these patients were on maximally tolerated ACE or ARBs prior to starting the study, which is really important because I know I see a lot of patients coming for consultation who are on 5 milligrams of lisinopril. And, in the studies, those patients would have been taken all the way up to the maximum tolerated before screening for the study. So really important that that gets addressed as well. So thank you. You mentioned the flow study earlier, which I think is really new data for many people out there. And I'd appreciate if you could just give us a synopsis of the results of that study as well.
Yes, so the flow study was published in July 2024, and it examined the effects of semaglutide on chronic kidney disease and type 2 diabetes. The people enrolled had type 2 diabetes, and they had an eGFR between 20 and 75 with a UACR that ranged from 100 to 5,000. And they were randomized to semaglutide versus placebo. The trial lasted about 3.4 years. And what's an interesting tidbit about this trial is it actually was stopped early because of an interim analysis that showed benefit. Ultimately, the trial showed that semaglutide compared to placebo showed a 20% risk reduction in the development of a kidney-specific composite endpoint. This composite endpoint included onset of kidney failure, a 50% reduction in the eGFR, or death from kidney or cardiovascular-related causes. So ultimately, just in January 2025, the FDA has updated the label for semaglutide to include the indication for injectable semaglutide for treatment of CKD in people with type 2 diabetes. And these data are very exciting to see that we have so many now options, and 2 options specifically in anti-hyperglycemic therapy, where they have not only anti-hyperglycemic effects, but they also have this renal benefit.
And to point out that the studies all demonstrate benefit over and beyond the impact on glycemic control. So we're dealing with these complications from 2 different directions, which is also very exciting. So let's get to the part that really discusses what the ADA recommends for monitoring for CKD and for choice of anti-hyperglycemic agents in this population.
So the ADA recommends assessing kidney function and yearly UACR screening for people with type 2 diabetes. People with known CKD and type 2 diabetes should have monitoring 1 to 4 times per year. A very helpful guide that I find is the KDIGO heat map. This is a color-coded chart that takes into account the albuminuria degree and the eGFR level to help clinicians as far as assessing the severity of the CKD, whether they should treat or not, and whether they should refer to a nephrologist. The ADA recommends both SGLT2 and GLP-1 receptor agonists with proven CKD benefit to be considered as anti-hyperglycemic therapies that also reduce the risk of kidney disease progression in people with known CKD. And the ADA does define the people with known CKD as an eGFR less than 60 or a UACR over 30. It's important to know the treatment goals we are aiming for. So when you start a therapy, we are aiming for a reduction in the UACR by at least 30% with people with an albuminuria level over 300 in order to slow the progression of CKD.
So in both cases, the SGLT2 inhibitors, the GLP-1 receptor agonists, would you only use the agents with FDA indication for slowing progression of CKD events, or do you use whatever's preferred on the patient's formulary?
So I would prefer, obviously, to use agents that have proven efficacy and that are consistent with the FDA indication. But I definitely acknowledge that sometimes or oftentimes we are limited by our patient's insurance formulary and the cost of the medication for our patients. So if that is the case, I would provide the agent which is in the SGLT2 or GLP-1 class that's on the patient's formulary.
As a practical clinical point, if you write in your record that you are prescribing this medication for, in this case, the CKD indication, and you're prescribing it because it's FDA approved, I find that that goes through the prior authorization process. You know, the MAs put it on the form, and that helps us sometimes get something that would be considered not on the formulary. And then I push forward for a formulary exemption if they're being charged a higher copay as well. It doesn't always work, but it is worth, I think, a try if you just are really careful with how you put the information in your records.
And we have the option when we write the prescription in our electronic medical health record, we can link it with diagnoses within the prescription, which really can help. So if you link it with diabetic nephropathy, or you link it with chronic kidney disease or microalbuminuria, it can help actually the prescription go through as well.
That is also a really good point. So thanks for sharing that. So when seeing patients with type 2 diabetes and chronic kidney disease, what considerations do you weigh in your choice of which class of medications you want to employ?
Well, I'm definitely, when I'm trying to prevent CKD, trying to take the whole person into consideration. So I'm not only considering medications, but also considering their lifestyle and diet as a key factor in trying to prevent CKD or reduce the risk of progression of CKD. I focus definitely on their blood glucose control, their blood pressure, their cholesterol, and avoiding renally toxic medications like we discussed earlier. If they have albuminuria, I will start an ACE inhibitor or an ARB. And subsequently, or in parallel, I will start an SGLT2 inhibitor or semaglutide if they have hyperglycemia. Additionally, if I'm not attaining my goal of 30% reduction in UACR after uptitrating the ARB or ACE, I do consider the nonsteroidal MRA finerenone as well.
Well, those numbers are really, really helpful. So I'm trying to tease out, in your opinion, what your views are on whether or not you would ever start a GLP-1 receptor agonist over an SGLT2 inhibitor in this patient population.
That question seems to come up a lot. I think it's highly debated among endocrinologists. Generally, I believe that these medications are complementary and they're not against each other. It's not one or the other. It's not one over the other. We have to treat our patients each as individuals and in a personalized approach. So these medicines are very complementary. And even though we do not have a trial that's randomized, controlled, looking at both the agents compared to the monocomponents compared to a placebo long-term trial in renal disease, there are post hoc analyses showing that there is continued benefit even on top of background therapy of either an SGLT2 or GLP-1 receptor agonist. And I'm pretty convinced by those data. Additionally, we are learning more and more about the unique benefits of each class in areas such as heart disease, obesity and weight loss, heart failure, and sleep apnea, just to name a few. More and more indications and studies are coming onto the horizon with these agents. So for this reason, I often use these classes of medications in combination, not only for glucose lowering or renal benefit, but also the other non-glycemic benefits that have been proven. So to answer your question, I do use GLP-1 receptor agonists. Maybe it'll be earlier in the sequence of therapy than an SGLT2 inhibitor because I'm trying to address weight loss maybe initially, where I will have more of an effect from, say, a semaglutide than an SGLT2 inhibitor. But more often than not, I'm using these medications in combination.
Yeah, I have to agree with you. I do think that there are circumstances where the GLP-1 receptor agonist might be more appropriately on a first line. So if a person has GFR that's significantly less than 45, they're not going to get any glycemic benefit. So if they need glycemic control in addition, the GLP-1 receptor agonist, or, if their A1C is really high and they really need a powerful A1C reduction, I'll generally start with the GLP-1. And one of the nice things about it is, I'm sure if somebody starts with a really high A1C and you start them on an SGLT2 inhibitor, they're more likely to get some of the hemodynamic and perhaps even genital mycotic infections. Right? But if you bring their A1C down with the GLP-1, then they're less likely to have side effects from the SGLT2. So that's kind of my thoughts, but I was interested in hearing if you were in agreement with that. One last thing that I just don't think we really covered, and I know that you can give us some insight in this, but more people with chronic kidney disease and diabetes die of heart disease than of their kidneys. So we have to be looking at treating both problems concurrently as well. Well, there's a lot of new research studies that you're participating in and are out there. What excites you most? What are you really looking forward to seeing coming out in the near future?
Well, I'm not involved in all of the research studies, but there are a few new agents that are coming down the pike related to CKD in type 2 diabetes. But what really is interesting, I think, is how we're expanding even the medications for people without diabetes. And I'm interested also in seeing the new data on using newer agents for people with type 1 diabetes and CKD. So these are some of the newer studies, exciting things in CKD, just in this field that I'm looking forward to.
Great. And as we wrap up, are there any other points you'd like to share with the audience that we haven't already covered?
Yes, I do. So a couple years ago, we wrote a commentary that was interviewing people with CKD and a couple individuals on hemodialysis after developing ESRD. And one of the eye-opening discoveries I learned in doing these interviews was that these people who had end-stage renal disease didn't know that they had renal disease until they were very close to needing renal replacement therapy. And so I would just emphasize that all clinicians should be talking frankly with their patients about kidney disease and talking about it early, whether it's in the pre-CKD phase where we can prevent chronic kidney disease so that they understand that CKD is highly prevalent in type 2 diabetes and we need to be doing everything we can in order to prevent it from developing, or talking frankly with the people who have known CKD so they understand all the things that we're doing in order to prevent the progression of the condition. And in fact, these patients that we interviewed felt kind of blindsided in the end that they didn't actually realize they had this progression. So definitely talk early and frankly with our patients about CKD. I think we're in a really great place now. I'm excited about the growing body of evidence of medications. I'm really excited that we can treat each person with a more personalized approach now that we have a toolbox of options available to prevent the progression of CKD and type 2 diabetes. So looking forward to the future.
Liana, thank you. I really love your call out. We need to be talking to our patients, identifying it, looking at it, put it on the problem list, remembering to address it, treating them appropriately with the preventative therapies. Thank you so much for joining us today. For the audience, we've been talking to Dr. Liana Billings about how to incorporate SGLT2 inhibitors and GLP-1 receptor agonists into the management of patients with type 2 diabetes and chronic kidney disease. I want to thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on type 2 diabetes. This is Dr. Carol Wysham for the Medscape in Discussion Type 2 Diabetes podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.